quién sabe qué le pasó. Lo que me dio mucho gusto fue que me contestó muy rápido. comunicar a todos los panelistas y asistentes de esta sesión, que esta sesión está siendo grabada y transmitida por Zoom y simultáneamente por YouTube, Facebook y canal Imagen TV UABC. Contamos con un canal de YouTube en español, que es Divulgare, y otro canal de YouTube en idioma inglés, que es RemiTB. La transmisión de este evento en los distintos canales se realiza con el apoyo del Centro de Estudios y Producción Audiovisual CEPA de la Universidad Autónoma de Baja California, a quien le damos las gracias por su excelente trabajo. Es importante señalar que este foro está siendo realizado gracias al apoyo de diferentes instituciones, entre ellas la Escuela Ciencias de la Salud a través del Programa de Internacionalización en Casa de la Universidad Autónoma de Baja California, la Comisión de Salud Fronteriza México-Estados Unidos, la Red Temática Binacional de Salud Fronteriza, la Red Multidisciplinaria de Investigación en Tuberculosis RemiTB, el Centro Nacional de Programas Preventivos y Control de Enfermedades de la Secretaría de Salud del Gobierno de México y a la Red Nacional de Investigación para la Prevención y Control de la Tuberculosis en México. El Foro Virtual Internacional de Tuberculosis 2022 tiene como objetivo generar un canal de acceso a la innovación científica y a la colaboración biomédica a nivel internacional y nacional con respecto a la prevención, el diagnóstico y el tratamiento de la tuberculosis, con la de cumplir con la estrategia define la tuberculosis establecida por la Organización Mundial de la Salud. La estrategia busca reducir en un 90% el número de defunciones por tuberculosis y un 80% la tasa de incidencia de esta enfermedad para el 2030 respecto a los valores de referencia del 2015. La tuberculosis, desafortunadamente, sigue siendo una de las enfermedades infecciosas más letales a nivel global. Cada día mueren más de 4.100 personas de tuberculosis, lo que se traduce a 3 muertes por minuto a nivel mundial. Es importante recordar y enfatizar que la tuberculosis tiene cura si se detecta a tiempo y sobre todo
if it's detected early, and especially if we complete the treatment. Likewise, we'd like to remind all of you that we'll issue diplomas. Please go to our website, RemiTB website, to make sure you enroll. And for those of you who have not done it, you will find the link for the registration form. You can also use the QR code that you will see on the screen. You only have to register once. Additionally, I would like to mention that for the general public, we want to invite you to participate in this Dia de Muertos literary contest. This is an initiative through the Health Science School by the University of Baja California, RemiTB, and the National TB Network in Mexico. We want to invite you to participate in this literary contest in order to create awareness about TB and to contribute to the prevention, control, diagnosis, and treatment and follow-up of this disease within the communities. Everyone can participate here, regardless of their school. The terms and conditions are as follows. This literary piece should be you should be the author of such a literary piece, and it can be a humorous piece. And you have until October 30th. It's the deadline for submitting your application. If you want to, for further information, go to remitb.org, or you can also email us. Now I'm going to pass the floor to Dr. Francisco Javier Navarro, who is Dr. Monge. He'll be moderating today's session. Thank you, everyone. Dr. Francisco Monge, you got the floor. Thank you, Gilberto. Good morning, everyone. And yes, we're going to continue with the first speaker for today's session. We have here today Dr. Paula Fujiwara. Dr. Paula Fujiwara, she's an MPH, and she is also the chairwoman for the Global Plan to End TB 2023-2030. 2023-2030 is an work initiative that started in July 2022. Dr. Fujiwara, she has been a scientific advisor for the Asia Pacific Cities Alliance for Health and Development, and she has provided technical assistance and policy development for TB programs in Africa, Asia, and Latin America. Dr. Fujiwara, she was a leader for the efforts to convince the WHO to declare TB, zoonotic TB, as a priority, health priority, declaring the Union as one of the authors for the zoonotic strategies for 2015 efforts. And this is a joint effort between the WHO, the Animal Health Office for the UN, and other offices. They work together in order to achieve this goal. Delta's proposals were fundamental to make sure that the bovine and zoonotic TB were included in the political declaration for 2018 for the high-level meeting, the UN for TB, which will take place again in year 2023. Currently, Dr. Fujiwara, she works actively with the technical official groups for the G20 on TB and One Health, and the prior period to the meeting that will take place in October 2022 in Indonesia. From 1992 to year 2000, Dr. Fujiwara, she was member of for the CDC in the US, and in the offices for TB control in the city, in New York City. At that time, she managed to drop the incidence of TB in 2/3, and multi-drug resistant TB almost disappeared. Dr. Fujiwara, she completed her medicine education in the University of California, San Francisco. She also has a public health a master's in public health and a science master's by the Berkeley University. She has published several papers on public health for controlling TB, including multi-drug resistant TB and zoonotic TB. Today, Dr. Paula Fujiwara will talk about One Health platform using big city mayors to address zoonoses beyond TB. I remind all the speakers that you have 40 to 45 minutes for your presentation, and then we'll have 10 to 15 minutes at the end for a Q&A. Thank you. Welcome, Dr. Paula Fujiwara, and please take it away.
Well, thank you very much, Dr. Monge. And as I could see by the title, it's a lot to unpack here. So the presentation is going to be in 3 parts. I'm going to talk to you about the global plan to end TB 2023 to 2030, some of the lessons that we've learned from zoonotic TB, although I will not dwell on this so much because the next speaker will be talking about this topic in the context of One Health. But I want to concentrate on the Asia Pacific Cities Alliance for Health and Development, or APCAT, because it has developed a One Health platform for zoonoses beyond tuberculosis. And so we'll talk about the specific example of rabies at the end of this presentation. So let me start with the global plan to end tuberculosis. As was stated, I was the chair of the task force to develop this plan and also develop the previous 2 iterations of this plan. And this is an advocacy plan from the Stop TB Partnership, which is the advocacy arm for global tuberculosis. This is the 5th edition, and it's linked to the 2023 United Nations General Assembly TB meeting, high-level TB meeting, which will take place in September of next year. And this is something that, yes?
Can you put the full screen of your presentation, please?
It's on my screen. On my screen, it's showing it's a full screen.
Okay. Okay. Did you hear that, Raquel?
Yeah, maybe if you can. Yes, that's it.
Now it's full screen now. Thank
okay,
you.
sorry. Okay, sorry about that. So where was I? So this is the 5th edition, and it's linked to the UN General Assembly high-level meeting that's going to be happening next year. I want to talk about the effect of COVID-19 on the TB effort, and then go into the plan, and talk about what is it, the cost that what are the numbers that we need to determine the end of tuberculosis. And we'll talk about the return on investment, the cost of inaction, and the resource needs. For this plan, this is the first time we're talking about a TB vaccine as something for treatment and prevention. And then I'll mention some of the specifics about zoonotic TB that are in this plan. So the first thing is the COVID-19 pandemic and tuberculosis. Was it a friend or was it a foe? Obviously, both are transmitted by the air. There are similar public health interventions. For example, contact investigation, airborne infection control. But what COVID-19 did was it took an already weak infrastructure for tuberculosis, and it took the money and the personnel, and it was all diverted to COVID-19. But I think what COVID-19 did show was the power of political will. And with that political will, we were able to get a vaccine within 12 months of it starting. Yet with tuberculosis, we're dealing with a vaccine that's over 100 years old. So what happened? So this is an article by Madhukar Pai and his colleagues from the New England Journal of Medicine this year, and he compared the data from 2020 to 2019, and we saw that there was a 18% decrease in the number of people diagnosed with tuberculosis. Out of the 10 million estimated cases, only 5.8 million. We had the first year-over-year increase in deaths since 2005 at 1.5 million deaths. We had a decrease in the number of people drug-resistant tuberculosis that were diagnosed, a decrease in the use of preventive therapy at 21%, and also a decrease significantly in spending for tuberculosis. So the Global Plan to End TB 2023 to 2030, I need to emphasize that this is a people-centered, rights-based approach. And what do I mean by people-centered? Before we should talk about patient-centered, and that's not enough. It's not just about the patient with tuberculosis. So we then started to think about person-centered. Okay, this person is a person with tuberculosis, but that's not enough. People-centered means that it involves everyone around the person, not only the person with tuberculosis, but family, the medical personnel, and the community. And it's rights-based because of the very important role of the civil society in putting together this plan. So obviously there are 9 chapters, and obviously we're going to be talking about the investment packages in a minute, how to scale up diagnosis and care. But I want to concentrate on 2 chapters, 2 points from 2 chapters, and that is chapter 4, which is scaling up TB prevention, and also chapter 7, which talks about key and vulnerable populations. So this is about zoonotic TB, specifically in this global plan. And for the first time, this plan is using a One Health approach. It's looking at, when we talk about One Health, we talk about this triad of the humans, other animals, and the environment. But with zoonotic tuberculosis, we need to address the bovine source. And in humans, it's mostly foodborne, and it's mostly from cattle. There's an important collaboration in One Health with what's now called the quadripartite, used to be called the tripartite, which consisted of the World Health Organization, the Food and Agriculture Organization of the UN, what used to be called the OIE, but is now called WOA, or the World Organization for Animal Health, and newly in this year, the addition of the United Nations Environmental Program. What the One Health approach does, and I'll be getting into this in this presentation, that it applies to coronaviruses and other zoonoses to protect us from future pandemics. When we talk about zoonotic tuberculosis, we talk about them as a key and vulnerable population. And there are 3 different categories for this. And zoonotic tuberculosis actually fits in the first one. It's people that have increased exposure from working or in their living situation, so they have close contact with or live with livestock. They ingest raw or unpasteurized milk and also blood products. And they also belong to another category. We think about the people who live with these livestock. A lot of them are rural, nomadic, pastoral, and they have limited access to quality TB services. And the third group is the people that are increased risk because of their immune system is compromised. So what do we want from this global plan? And we have the goals by 2030 because it's the end of the Sustainable Development Goals. So we're linking it with this. And we want to make sure that we diagnose almost everyone with tuberculosis. And we want to address the high-risk populations. As I said, one of them is the zoonotic TB, but it includes people with diabetes, children, minors, etc. We want to make sure that 50 million people access treatment for tuberculosis, and this includes almost 5 million children who have tuberculosis and a couple million with drug-resistant tuberculosis. it's very important that we address the source of tuberculosis disease, and that is 35 million people who have infection, and we need to address them. And for the first time, we are working to have at least one tuberculosis vaccine by 2026. And compared to that 2015 baseline when the SDG started, we'll have an 80% decline in tuberculosis per 100,000 population and a 90% decline in deaths. So what is the money that we need to get there? The message that I want to convey is that tuberculosis is an excellent long-term return on investment. For every dollar that's invested, you can have a $40 return on your money. And this slide shows the world investment on the left and the low income countries and the lower middle income countries on the right. The yellow is to 2030, which is the end of this particular plan, but the effects go through 2050. So for every dollar that you invest, you get a $40 return on investment. And if you look at these lower income countries and lower middle income countries, you get a $59 return on every dollar that you invest. What do we need to actually get to the end of tuberculosis? By 2030, we need to spend about $250 billion. Most of this is for TB prevention and care. But as I said, what's new is that we have TB vaccination. And if we break down the resource needs for research and development, most of it is going to go for the medications, but then we have the vaccines, the diagnostics, and then we have to continue the basic research so we can actually implement the end. If we look at the resources that are needed for care, prevention, and vaccination, this starts in 2023 next year and then goes to 2030. You can see these bands. You see that at the bottom that there's diagnosis is going to need quite a bit of money. However, treatment and prevention is a relatively small amount of this cost. This is followed by the three bands of health systems, enablers, and program costs. But you can see that in 2026, you see this big yellow block, and this is the effective vaccines, which will start in 26 and ratchet up to 2027, and that will also help us end tuberculosis. What do we have this plan doing for us? It is an advocacy plan. It is a costed plan, as I've just shown. But basically, we need to show countries that it can be done and provide the technical assistance. Tuberculosis has always been seen as a poor cousin, a poor relative, and so we're given a little money and we say, you know, do what you can with it. But what we want to encourage countries to do is to say, this is what we need to end tuberculosis. So we'll have to help them put together these plans. We're going to be developing or are developing already advocacy materials for resource mobilization for different groups. Donors need some kind of advocacy, scientists, civil society, so special needs populations, all of them need these different kinds of advocacy materials. We are aiming, as is pointed out, to the United Nations high-level meeting on tuberculosis, the second time that we're having it since 2018, and that will happen next year. And then what's important, I'll be talking a little bit more about this, are the G20s, the countries, these are the countries with that are addressing a lot of the issues in the world. And there are many side meetings over 2022 and 2025. And I mentioned that Indonesia, India, Brazil, and South Africa, most of which have very high burdens of tuberculosis, is very important. I'll be talking about Indonesia in detail. We also need to link the advocacy plan to the 8 other non-TB SDGs. For example, the issues of gender equality and climate and the catastrophic costs. And then the Global Fund just had its replenishment for 2023. I have to say, unfortunately, that it did not reach its goal of $18 billion. It only reached about 14 billion. Now, this is a living document. It's a digital report. It has not been actually printed out, but you can download a PDF form of the plan, and it will change through the next 8 years. So advancing One Health, this is the section. I just want to say, what are some of the lessons that we've learned from zoonotic tuberculosis? The next speaker will go into more detail about this. I want to talk about the zoonotic TB roadmap and how to integrate zoonotic TB into One Health. Just some brief comments about this. So the problem is what are the two major challenges to understand the impact of zoonotic tuberculosis? And part of the problem is that we lack systematic surveillance for bovis in some of the low-income, high-burden countries where bovine TB is actually present. And unfortunately, the commonly used lab test can't differentiate bovis from tuberculosis. It only identifies the MTB complex. So what's the burden? The problem is we don't know. It's undercounted, it's incomplete, and it's unsystematic. The WHO in 2017 put out some estimates saying that there's about 140,000 people with zoonotic TB with 12,000 deaths. And Africa and Southeast Asia are have most of the burden. The United States is one of the few countries that actually reports on bovis, and they say it's about 2% of the reported cases. And there was a study last year in Zoonoses and Public Health about the prevalence of M. bovis. And again, because it's undercounted, incomplete, and unsystematic, you see a pool prevalence ranging from anywhere from under 1% to 76.7%. Of the 19 studies, if you put them all together, there's an average of a 12.1% prevalence. But if you look at the genotypic studies, which are probably more accurate, you have a 1.4% prevalence. So I want to tell you how we got to the roadmap. In 2015, a group of colleagues and at the International Union in the zoonotic TB subsection got together and said, we have to have a call for action. So in the center slide on the top, you see these are the groups that came together to actually put together this article that was published in The Lancet in 2016. And what we wanted to do is to have global action for prevention, diagnosis, and treatment for zoonotic TB with the goal to get approval by the WHO by June of 2016. We were very lucky. At that time, there was this sense of ending tuberculosis. And so on the slide on the right, top right, you see all of the entities that were starting to be involved, the Global Fund, there was this One Health, nascent One Health approach, Sustainable Development Goals were already there, naming tuberculosis in SDG 3. Antibiotic resistance was a problem because of what's going on with tuberculosis. Activists started to get involved. There's the World Organization for Animal Health, the Food and Agriculture Organization of the UN, the World Health Organization's NTB strategy. And for the first time in that lower right-hand corner, you can see that the global plan at that time, 2016 to 2020, had zoonotic TB for the first time. And I can say with confidence that it was because of my pushing that we got zoonotic TB in there. But I think what's important is that see this picture of the people gathered together. This is the Global Caucus of Parliamentarians. So these are parliamentarians who said, we think that this is important and we're going to advocate for tuberculosis just like the world has advocated for HIV. So in the lower left-hand corner, we see there's a group of us that got together to actually galvanize the action against zoonotic tuberculosis. We were able to present this at the World TB, Global TB Program's Strategic Technical Advisory Group, which is the scientific entity for the Global TB Program, and they declared it as a priority. And they tasked us for putting together this roadmap for zoonotic tuberculosis, which is published in English, Spanish, and French. Because we had this roadmap, and without it, it would not have been possible. But because we had this, we were able to get the words zoonotic and bovine into the political declaration that came from that high-level meeting in 2018. Without that roadmap, this would not have happened. So just to briefly say what this roadmap contains, there are 3 components. We want to make sure that we have better surveillance. We want to reduce the transmission at the human-animal interface. And obviously, we have to strengthen all the partnerships that come along to address zoonotic tuberculosis. So in terms of improving the scientific and evidence base, we need to collect that data that we know that is so poor right now, looking at TB incidents, zoonotic TB incidents in people and also in the livestock. We want to improve our diagnosis to get beyond the MTB complex, use the tools to identify bovis, and try to identify and characterize zoonotic tuberculosis, and then address the research gaps. In terms of reducing transmission at the animal-human interface, we have to ensure safer food, and develop strategies to improve that safety. Instead of raw milk, we need at least heat pasteurized dairy products or pasteurized dairy products. The food source, the meat has to be improved too, and also to reduce the risk for people. Not everyone is at risk for zoonotic TB, so we need to identify the key populations and the risk pathways. And finally, this intersectoral and collaborative approach, we need to increase the awareness, engagement, and collaboration, have the policies developed, and the OIE, then OIE, now World Organization for Animal Health, is responsible for developing the animal health codes, implement the joint interventions between these two groups, and obviously we need the money. We do have a timeline and of these three components, and I think that we did have set guidelines for 2020 and 2025. I think we've made the most progress in this third column of strengthening the intersectoral and collaborative approaches. We still have to improve the scientific base. So what are the two main lessons from zoonotic tuberculosis? And I say it takes a village. So many of you in this audience may be academics, you write your papers, you just hope that someone listens, but we reach out to media. And so you can see in the upper left that the South Africa news organization started to pick up the story. When we said to them, did you know that you can get tuberculosis from animals and it transfers from animals? They were absolutely shocked. CNN picked this up. Health 24, a big UK publication, also became interested. This went on into the Spanish publications, French publications, and then we also use the conferences to amplify this message. For example, there's this World M. bovis conference that happens every 5 to 6 years. At that time, it was a 2014 one. We just had the most recent one this year in June. And then the union has a very active zoonotic TB subsection, and we have meetings and presentations at that meeting. But I think the other second lesson is that you have to involve the people that are affected, vulnerable communities, vulnerable people. You can see on the left, here's a zoonotic TB survivor who comes from the Maasai community in Kenya, and she got a zoonotic tuberculosis because of the practice of drinking raw milk and using the blood products for food. So now she's developed an NGO to actually educate her community about the need to have at least heat-treated dairy products. In the lower part of the screen, you can see that people who actually sell the meat are at risk for zoonotic TB. And also in Nigeria, there's a dish called fuku elegusi, and this is where the people actually seek out for food the pieces of meat that have the TB tubercles in them. On the right, you see people who work with animals. So here's a veterinarian who is a zoonotic TB survivor. And in the lower right-hand corner, you see the butchers, the veterinarians who are in the abattoirs looking for zoonotic TB. So these people are at risk. But let me move to the current One Health initiatives beyond tuberculosis. And here's a statistic from the Food and Agricultural Organization. 60% of all human infectious disease are zoonotic, and 75% of them jump species. So before I move on to going beyond TB, for the first time, again, the Global Fund, which provides 80% of the external funding for tuberculosis, has put One Health into its newest strategic plan that starts next year for the next 5 years. And this is the basis of the constituency from the German constituency. So it looked at if you look at the strategy, it lists One Health several times, zoonotic disease, and One Health, it talks about pandemics, it talks about antimicrobial resistance. And at the end, it says, including One Health approaches by ensuring integration with TB prevention and care measures. Again, the first time ever that this has actually been included. The other thing that happened was that there is a new One Health high-level expert panel on One Health called OLEP. And what they did was they looked at the definition of One Health and they expanded it Before it was just like, the interaction between the environment, the humans, and the animals. But they say that it has to be a balanced system between these three components, and it has to be equitable. It has to include everyone. There has to be a socio-ecologic equilibrium and balance. And humans have a special responsibility because we have to take care of animal welfare and also the environment. And obviously the use of many different sectors. So putting them all together in the picture, you can see that if we have communication, coordination, collaboration, and capacity building, we have the possibility of One Health, where we have healthy ecosystems, healthy animals, and healthy humans. And the quadripartite, which I mentioned before, they endorsed this new definition in December of last year. So this is all new information. One Health globally is a big factor. I think it's because of the probably speared by the COVID-19 pandemic. The G7 in last year and this year made One Health a proposition. The Rome G20 summit and also the G20 summit in Indonesia this year has put One Health in the picture. The National Academy of Sciences in the US has talking about this, the Euro Food and Safety Authority, but the World Bank is now putting money into this. They have developed a fiduciary intermediary fund for pandemic preparedness response in the context of One Health. And so far, $1.4 billion has been pledged of the $10.5 billion needed. I mentioned the G20 in Indonesia, which is coming up in actually November of this year because of the work that I'm doing with APCAT. And this will be preceded by the One Health Day, which is celebrated each year on November 3rd. Let me move to the work, the specific work of APCAT, the Asia Pacific Alliances for Health and Development. You may ask, what is the T? Where is the T? And that's because this started out as a work against tobacco. This is work funded by the Bloomberg Philanthropies. And the original goal was to actually combat the use of tobacco so that NCD rates would go down. It started in 2016. And this is what I consider a unique regional alliance of mayors. So working at the local level and subnational leaders, and there are 78 cities involved in 12 of the countries of Southeast Asia, basically all of the countries of Southeast Asia. They worked collectively with political commitments, and their whole mantra is, we have local solutions for local problems. So they band together for new partnership opportunities. They want to use their resources well to have stronger health system outcomes. Why do we work with mayors? Because mayors, instead of being mayors that just ceremonially cut a ribbon, make a nice speech, these people actually have control over their budget and control over the agenda of what they want to do for their cities. So we have a board of directors and a management unit, obviously, but the partners are many. The World Health Organization as a technical agency, donors, NGOs, universities, and the public sector. But I think what's very, very useful is to remember I mentioned the parliamentarians that pledged to address the whole issue of tuberculosis. Well, parliamentarians have come together for APCAT, and they have the money, the resources, and can do the legislation. But also we have APCAT Media, which are a group of newspapers, media outlets that can actually broadcast the work of APCAT. I need to go back and talk to you about the tobacco control because you can see why it works. These are concrete actions for mayors using the Empower strategy for tobacco control. Basically, a mayor could choose all or one or several of these. They could say, we want a smoke-free city. We want to ban the advertising. We want to make sure that the tobacco packs have a pictorial warning showing those awful diseases on the packages. We want to make sure that we raise taxes. We want to stop the use of the tobacco organizations from interfering with our work. We want to address NCDs, et cetera, et cetera. So these are things that they can actually concretely do. And the whole goal is to reduce the prevalence of smoking and secondhand smoke. And therefore we have the reduction in non-communicable diseases. And the strategies below, they have many different strategies in how to address tobacco control, TA, legal assistance, partnerships with civil society, et cetera. Does it work? And yes, it does. So here are some of the key achievements for Indonesia. They have 292 smoke-free cities as of last year. In Kuala Lumpur, the capital of Malaysia, they've implemented smoke-free environments. I came back from Malaysia last weekend, and basically this is a country where there are a lot of smokers, but in the government buildings, in the restaurants, in the hotels, you do not see people smoking, and there are signs everywhere against smoking. Not as well done in the when you're actually outside, but that is also getting better. In the lower left, you see in Timor-Leste, the packaging warning. The goal is to get plain packaging. So all it says is a little name of the name of the cigarette company, and along with just a plain color. But on the way, we have what we call pictorial warnings. So Timor-Leste has a 95% coverage of the package of the cigarettes with pictorial health warnings. Philippines, they've had mobilized the public for smoke-free environments. In India, they've had regulations to remove designated smoking areas. So this is effective. This consortium of mayors is very effective. In terms of the programs, obviously tobacco control, but now they've moved into non-communicable diseases, communicable diseases, and just as of last year, they have decided that One Health is important. As of December of last year, they hadn't even heard of One Health, but now they're saying they have embraced this, and I'll talk about what the concrete things that they've done. So AP-CAT is a model for One Health. This is a platform for basically any kind of public health intervention. It builds political leadership, ensures the sustainability and accountability of leadership at the local and subnational levels. So this is the focus. This model is transferable, generalizable. You saw the good effects of tobacco, but now they are moving into COVID-19, tuberculosis, and also rabies, which I'll talk about in detail. There are key strategies: sharing the lessons, connecting cities to city. Remember, this is a consortium of mayors from 78 cities in 12 countries. So they get together and they talk about what worked here. Can it work in your city? And they use the government resources they can actually implement on the ground, and then obviously monitor their outcome. So let me just end with talking about this last component, which is this AP-CAT actions for rabies control and prevention. Rabies is another zoonotic disease, and this work is going on in Bali, Indonesia. So what's the burden of rabies globally? There are about 59,000 deaths per year in 150 countries. Most of it is from Africa and Asia. However, similarly with zoonotic tuberculosis, it's underreported. We don't have the estimates, so we really don't know the true burden. But we do know that most of it comes, 99% of the rabies is dog mediated. And the burden of disease actually is borne by poor and rural populations. Again, maybe with this link to zoonotic TB. And the bites, unfortunately, 50% of them occur in children under 15 years. So what about Indonesia? Rabies is endemic in 20 out of their 35 to 37 provinces, and only a few are rabies free. They have about 100,000 dog bites a year. This is probably an undercount. Same for the number of human cases of rabies a year, 150 to 300. And Bali, where we're implementing this, was actually rabies free until 2008. But so why are we doing rabies prevention in Bali, Indonesia? First of all, we found out that the World Organization for Animal Health brokered getting vaccines from the Australian Ministry of Agriculture, over 200,000 doses of rabies vaccine, and supplemented by the supplies from Indonesia. And Bali said, yes, rabies is important to us because we are dependent on tourism and we don't want our tourists to get bitten. So 80%, you see in 2019, over 25 million tourists, and they contributed $14 billion per year in revenue. And because of the pandemic hit, there were 1 million visitors in 2020. And if you can really believe the statistic, which I read from this website, that in 2021, when the government totally shut off everything, there were 51 visitors. There are 500,000 dogs. Many of them are unvaccinated. And the reason why Bali was chosen, because this is where the G20 meeting will be happening in Indonesia. So the feeling was we'd like to have a vaccine campaign to show that we are doing something. So as mentioned, this is a collaboration with the Australian Ministry of Agriculture, the Department of Agriculture, and the Ministry and the government of Indonesia. The World Organization for Animal Health and the WHO are providing the technical assistance, and APCAT, the organization with which I work, is actually responsible for that local implementation with mayors in Bali. As of December last year, this is the first time we introduced this concept of One Health to the mayors. They enthusiastically said, this is something that we want to do. This was followed by a high-level webinar in June of this year that was attended by over 1,400 people on the sub-national leadership in One Health, and this is in preparation for the G20 in Indonesia. This is followed a month later by a partnership meeting on One Health and rabies for Bali, and then followed by an interministerial meeting a week later looking for the coordination of this effort of One Health and rabies. So the strategies were to build the political commitment, capacity building, the technical assistance, and working with civil society and donor coordination. So in terms of local leadership, there was a meeting with a group called the Bupati, the regencies, a group under the level of the province in one of the cities in Bali, and they said that we wanted to have better regulation, make sure that the public is aware of the rabies. And we have some actually laws in place, but we want to strengthen them and then actually use the vaccine. This was followed by a meeting with the vice mayor of Denpasar city, which is the biggest city in Bali, the capital city of Bali. Again, making this advocacy, making this partnership with community, and actually saying, we can use the resources for the rabies effort. This multi-sectoral partnership came together, and it was a meeting on One Health in particular, more than 80 participants from 58 organizations, the APCAT, along with the Food and Agriculture Organization, the World Organization for Animal Health, and the union actually sponsored this meeting, and the aims were reinforced commitment of the stakeholders regarding rabies using One Health. And then to assess their efforts, they did a SWOT analysis, strengths, weaknesses, opportunities, and threats for One Health in rabies prevention in their province, and then develop plan of actions to identify strategies that were outlined from the previous webinar on One Health. They identified these concrete actions, basically very similar to what was going on, what they did with tobacco, to have regulation. Remember, these mayors can regulate for their cities. So they wanted to regulate rabies control and prevention, have the vaccine project, but also control the growth of dog population by neutering, to explain to the community why this was important. Again, One Health came up. They want to have a One Health task force to strengthen their partnership, have the funds available, do the M&E. And finally, the most important thing is to share the importance of One Health as a solution for many health problems that the G20 has. And finally, the APCAT is putting together the actual activities on the ground, strengthen the leadership of these people, offer the TA and technical assistance, because we have this experience from our tobacco work. We worked with Bali before, so it wasn't a matter of trying to get to know these people. We already knew the local legislators, and so we'll be able to work quickly, and then also to facilitate this One Health approach, and then do the coordination, planning, implementation with the partners, and then effectively use the resources. So remember how I started in this last part of the presentation. 60% of human infection diseases are zoonotic, and 75% jump species. So we need to think of One Health. This is all health. And this is healthy ecosystems, healthy animals, and healthy humans. And this is going to be needed to address the pandemics that come in the future. Thank you very much.
Muchas gracias a la doctora Paula Fujiwara.
Thank you, Dr. Paula Fujiwara, for your excellent presentation. Now we're open to questions. We have a few questions for Dr. Fujiwara. We're going to start with the first question. It's in English. I'm going to repeat this question in English.
Okay. La pregunta dice, doctora Fujiwara, how can we include the migration into the One Health perspective to have a positive impact?
Yes, yes. Do you want me to answer, or do you want to do several questions first?
You answer first.
Okay.
Please.
All right. All right.
Go ahead.
Okay. So this is an interesting idea of the whole issue of migration and One Health. I'd have to think about that. Certainly, when I think about the global plan to end tuberculosis, migration is a very important part of this because people obviously move. So I would think that we can actually incorporate the ideas of One Health. For example, many of the populations that we deal with are migratory. When I'm thinking about the zoonotic aspect again, and people move with their animals. So I think that this is something that we need to incorporate with the whole idea in the instance of tuberculosis with the One Health. So I think that it can be done. It should be included. The person that I mentioned that had the zoonotic tuberculosis in Kenya, she comes from a pastoral community. So these are people that are migrating within countries and between countries because they don't often have the borders in mind as they're moving across.
Okay, thank you very much. There's another question. The question says, do you have information regarding TB control at the international border crossing context?
Well, you probably are aware that the United States and Mexico has a binational TB control activities. Some of these things happen in the other countries. I'm not quite sure that if this is going on in a formal way, but certainly at the global level, since WHO has the information, they can share this information between the countries.
Okay, another question. At the global level, which countries have the best surveillance system for zoonotic disease from the One Health approach?
Yes, you can tell from my presentation that we do not have very good global surveillance of zoonotic TB. I would say that probably the United States does have it. As I say, they actually speciate for bovis in their TB. If you look at their TB report, there is a section on the bovis, and I think this is because of the relationship between the borders between Mexico and the United States. But the other countries, it is very unsystematic, extremely unsystematic. So you saw when I presented the data from the 2021 study, it's all over the place because they're looking at little groups here and there rather than looking at it from a systematic point of view. So unfortunately, I have to say that it's not very good, and the United States is probably the best where it's being done so far.
Okay, another question. Considering the impact of the COVID-19 pandemic on TB service systems worldwide, how many more years are there before we can meet the goal of eliminating TB in all countries? Wow, tough one.
Yeah, that's a tough one. I mean, I think that I think the lesson that we learned from COVID-19 is that if you put political will into the situation, you will get better results. I mean, I mentioned the example of the vaccines. In 1 year, we had multiple vaccines and we're still struggling with tuberculosis. So in the global plan, we have actually put resources in to actually catch up from what we lost during the COVID-19 epidemic, not epidemic, the pandemic. So it's hard to say what we'll do. We're going to be trying our best. And I think the most important thing is that we have to teach countries, every country, that we have to say what it is that we need, not what it is that we get for the money, because usually we don't get enough money to actually do the work. So we are actually working, for example, we're working actively with Nigeria, doing the modeling for the country. What is it that we need? And then we put it out there and we say, no, we're not going to just say, you know, that you haven't given us enough money. We need this extra money. So we hope this will happen. I'm optimistic. I have to be optimistic, but COVID-19 has had a detrimental effect on tuberculosis, as we all know.
Okay, there's another question. Do you think that molecular identification of Mycobacterium bovis in patients should be mandatory?
Well, ideally, if countries had the resources, that, you know, it should be done. But we are still getting away. The WHO has now said that, you know, we don't even want to use smear microscopy. We want to use more molecular methods. But getting countries then to, you know, countries' excuses, we don't have the resources. But the thing is this is where we have to advocate for these resources. And if we could do it, mandatory is hard. It's hard to tell a country that you have to do something. WHO can advise, but they can't say you have to do it. But ideally, if we could have the more accurate methods of diagnosis, that would be a better thing to do. But let's get away from just using the smear, which is still going on in so many countries.
Okay, they are typing another question. Raquel, do we have another question? We still have 1 more minute. Okay, let me see. Hold on, just Dr. Fujiwara. They are typing the question.
It's a long question.
Okay, the last question is ready. Okay, based on your experience, how we can start to work on a global effort in One Health, under the One Health perspective, to fight infectious disease, not only tuberculosis?
Well, I think that we are in a great moment, what I call the zeitgeist, because of what happened with COVID-19, the G7s, this is the ones that said we have to develop this effort. So this is where this One Health high-level panel on One Health has been developed, and this is coming. And then the other thing that happened, that's now it's kind of reactivated the whole idea of One Health, which has been going, One Health has been around for, over 30, 40 years. But now it's having this new effort. The other thing is that I think what's very important in the comment that the World Bank, as I mentioned in my talk, for the first time in July says we have a fiduciary intermediary fund that's dedicated to pandemic preparedness, but that includes One Health. So with that, they've calculated that they need just over $10 billion. They have a little bit over $1 million. So I think this is the kind of effort that we're going to need. And the use of the quadripartite, the World Health Organization, the FAO, the World Organization for Animal Health, and the UN Environmental Program, I think is going to help us to give the guidance. So this is what we need to do to make One Health really shine in a way that it hasn't in the past.
Okay, well, thank you very much, Dr. Fujiwara. Le agradecemos a la doctora Paula Fujiwara por esta interesante.
We want to thank Dr. Paula Fujiwara for such a great presentation, for answering so many questions. Thank you, Dr. Fujiwara. Thank you for being with us.
Okay.
Muy bien. All right. Now, moving on to following the agenda, before we move on, I would like to mention that this event is sponsored by PACMOB, with headquarters in Mexicali, Baja California, with offices in Ensenada and Tijuana. Backmouth Company also has distribution of their supplies throughout the country. We also want to thank the sponsorship from Visal Company, whose headquarters are in Guadalajara, but they have distribution and can ship to all Mexico. And it has an office in Ensenada. Okay, thank you. And continuing with today's agenda, we're going to welcome Dr. Ana Marcia de Sá Guimarães. Dr. Ana Marcia, he is a vet doctor. He is a master's in epidemiology by the São Paulo University. He is a microbiology doctor by the Purdue University in the US. Her line of investigation are animal TB oriented to bacterial genomics and the genetic variations in the Mycobacterial tuberculosis complex. Dr. Ana Marcia will present today's presentation, Control of Tuberculosis Epidemic in the Context of One Health. We want to remind Dr. Ana Marcia that she has from 40 to 45 minutes for her presentation, and then you have 10 to 15 minutes at the end for Q&A. Thank you, Doctor.
Falta solamente poner en presentación.
Now, Ana Marcia.
I shared, can you see the full screen?
It's in full screen. Go ahead.
All right. Thank you. Thank you very much for the invitation to be here. And I'm sorry I have to speak in English. I know it would be much easier in Spanish since I'm a Portuguese speaker, but my Spanish is terrible and my Portuñol also doesn't help. So, but I can understand everything. So if you guys want to later on ask questions in Spanish, will be good too. So the topics of my, oops, just a second, let me change the pointer here. So I'll go over 4 topics today in my presentation. And I think we cannot talk about strictly zoonotic TB without understanding the evolutionary history of the complex as a whole, the Mycobacterium tuberculosis complex. And then the main causes and the real impact of zoonotic TB in people that hear cattle and also in patients. The prevalence of zoonotic TB and bovine TB in the Americas. I will focus more in the Americas for this talk. And then at the end, I think how we can really try to control zoonotic TB using a One Health approach. So the Mycobacterium tuberculosis complex is a group of 12 ecotypes or species, and they have clonally evolved. So they all evolved from a common ancestor, and they're very, very similar genetically. So their genome is like 99.9% identical over homologous regions. And they solely evolved through SNPs, indels, and certain deletions that go up to 15 kb, the insertion of transposable elements, and certain duplications. So what happened is that there was a common ancestor for the Mycobacterium caneae, which was one of tuberculosis mycobacteria, and the Mycobacterium tuberculosis complex. And from that, they were some lineages were established by they were losing some pieces of their genomes, and this evolutionary reduction actually led to different host tropism and virulence. So each one of those lineages, they're either more adapted to humans or more adapted to animals. So for instance, we have Mycobacterium tuberculosis that is highly adapted to humans. We have Mycobacterium africanum, which is a cause of tuberculosis in West Africa, is also adapted for what we know, mostly adapted to humans. And then you have a whole group of animal mycobacteria that have been isolated from different animal species, and they're either more adapted to one species or another, or more with a broader host range, which is the case of Mycobacterium bovis. Mycobacterium bovis is the most well-known mycobacterium species, the most well-studied, the most widespread. And we're going to talk about it. It's host tropism, but it's a multi-host pathogen. So it is adapted to cattle, but it can infect many different host species. So with the advent of whole genome sequencing, we're able to go deeper into this phylogenetic classification of the group. And we see that even within Mycobacterium tuberculosis, there are different lineages, and they are separated by geographic occurrence. And then you have all the animal species for which much less is known. Some of these species, we have a few isolates, or they're isolated from only a particular group of animals. And then you have, of course, Mycobacterium bovis, we're gonna talk about it a little bit later on, but it also segregates according to geography. So I think one of the most important messages now that we're talking about zoonotic TB is the fact that while we have these pathogens that are highly adapted to humans, and they don't establish animal reservoirs, which means that animals are not part of the transmission cycle. The transmission of Mycobacterium tuberculosis is solely human to human. We have this whole range of animal species of mycobacteria that are highly adapted to animals, but they spill over into humans, and then they cause the zoonotic TB. The most well-known and pathogen for that, and the main cause of zoonotic TB is Mycobacterium bovis. But most of the other pathogens have also been once or eventually also isolated from humans, which means that they all have this zoonotic potential. They have all the potential to spill over from animals to humans. And when we think about the evolutionary emergence, for a long time, it was thought that the tuberculosis in humans came from animals, and now we know that they both evolved from a common ancestor. And actually, the emergence of the Mycobacterium bovis is even earlier. It was more more modern, I would say, than the lineages of Mycobacterium tuberculosis. But for a long time, it was actually, it is set in stone that the lineages that occur in the Americas, they came with European colonization. But there were some mummies in Peru that had lesions in the skeletons that were compatible with tuberculosis. And they actually, using ancient DNA technology, a group from Dr. Boss and Max Planck Institute, they were able to sequence the genomes of these bacteria, and they actually saw that they were very close related to Mycobacterium pinipidi, which is a pathogen that occurs in seals. So here is just to show you that the history of zoonotic TB has permeated the history of tuberculosis in humans for many, many centuries. And here, so before the TB was introduced in the Americas, the Mycobacterium tuberculosis was introduced in the Americas, we had circulation of zoonotic TB in Peru. And then using this ancient genome, she was able to date the origin of tuberculosis, of the Mycobacterium tuberculosis complex. And the most recent common ancestor was dated to be around 3,000 and 5,000 years ago, which is a much earlier emergence than initially thought, that it was with the out of Africa migration of humans. And so this is actually the most accepted theory right now, that tuberculosis emerged around 3,000 and 5,000 years ago, which is a long time for a pathogen that has been living with us, right? When I studied that we did in the lab, we also we dated the most recent common ancestor of Mycobacterium bovis, and we see earlier emergences, so it's around 735,000 years ago, which kind of is in agreement with archaeological findings of in bovis DNA human skeletons from Siberia that dated back 1,700 years ago. And it kind of also showed to us that the Mycobacterium bovis have this, sorry, it has this ability it probably was widespread, and it kind of permeated around many countries throughout the trade and the rise in the animals that were able to, when the growing population needed more and more meat and milk to survive. We see that the more basal strains of Mycobacterium bovis are from Africa and Europe. So the same occurs with the Mycobacterium tuberculosis complex as a whole. We believe it emerged in Africa. But if we take a look at the genomes that we use to do all these estimates, they are mostly from the Americas and Europe and some countries in Africa. Russia is only here because of one isolate from a human patient. So basically what happens is that most of the work that has been done with Mycobacterium bovis is it's coming from middle and high income countries. And a lot of countries from low middle income countries are not represented, and also countries from Asia mostly are also not being represented. So it's hard for us to really know what's going on in countries, because not all countries have the bovine TB control programs. But zoonotic TB is centuries old. We see that tuberculosis, it is with us for thousands of years, but the history of zoonotic TB is also old. So the transmission comes from raw milk, from meat products, from close contact with diseased animals. And to have an idea, when the data that we were able to collect, so around 1912 and 1937, 65,000 people died in England due to TB from milk. So it was a very well recognized problem, leading to deaths in children with extrapulmonary disease. So it was since 1892, people knew that the milk was a source of the pathogen, because Ernest Lederle infected guinea pigs with contaminated milk and was able to reproduce the disease. And then pasteurization came for other purposes in wine and in the food industry. And then in late 1800s, early 1900s, the pasteurization starts to become mandatory in few United States and European cities because of this impact that milk consumption was having on tuberculosis. And to have an idea on how pasteurization is effective, so in 1912, it was pasteurization was deemed mandatory in New York. And in the decade that ensued, 50% of the milk was pasteurized. And with that, there was a drop in 50% of the extrapulmonary TB deaths. And also there was a drop from 50 to 10% of the leishmaniasis TB being caused by Mycobacterium bovis. So pasteurization was very effective in controlling, it is effective in controlling zoonotic TB. Now we know, of course, much more about it. And we know that it's not only Mycobacterium bovis that causes tuberculosis, but there are also Mycobacterium capri and possibly Mycobacterium orygens. So Mycobacterium bovis is for certain the number one, if it is something that it is very well known, but it is a pathogen that is widespread in many countries. Only the countries that were able to really eradicate a disease that we don't find in bovis. But in capri is more the reports of isolation, they come from mostly from Europe and north of Africa. Cases in countries that have a surveillance system for zoonotic TB and capri may be up to 50% of the cases of zoonotic TB. And the difference between M. bovis and M. capri is that also M. capri will not be resistant to pyrazinamide, which is one of the problems of zoonotic TB caused by M. bovis. M. orygens emerged, the scientific evidence about it emerged in the past years. And it actually came from the fact that many migrants from South Asia that had zoonotic TB caused by Mycobacterium orygens. So there is a growing concern now that there is circulation of Mycobacterium orygens in the cattle from India, from Southeast Asia, and that may be a cause of zoonotic transmission. Another important aspect of Mycobacterium bovis, and from now on, I'll really focus on Mycobacterium bovis because as far as we know, is the main pathogen causing zoonotic tuberculosis, is the fact that the TB caused by this pathogen is a multi-host disease. Even though Mycobacterium bovis is a well-recognized disease of cattle, it is, the Mycobacterium bovis is able to infect many different host species with variable population persistence. So it ranges from spillover events, so that end host, the animal will get the disease and then will die with it, or established reservoirs. So you have animals that are that maintain the disease in the environment, they transmit from one animal to another, and they serve as a reservoir for the disease in cattle and vice versa. So this is a whole level of complexity because it's not only about controlling tuberculosis in cattle, but also in wildlife, which makes it much harder. So there are many high-income countries that have difficulties in controlling bovine tuberculosis in cattle because of the wildlife maintenance of the pathogen. So, and we can also not neglect the fact that the population is growing. There is much more contact between humans and wildlife, and this increased risk is also a problem that may come to, make it even more difficult to control zoonotic TB. And we see that Mycobacterium bovis, it transmits between the species irrespective of the genetic makeup. So the genomes of Mycobacterium bovis also tells us that it doesn't matter, there is no specific lineage more adapted to one species or the other. Mycobacterium bovis is a generalist pathogen, is able to infect different host species with variable population persistence. So this is a study we did with around 2,000 genomes of Mycobacterium bovis from the countries that were available. And we see that Mycobacterium bovis tend to cluster based on geography and the clonal complexes, which was one type of genotypic classification we had before genomes were available. And we see that the host classes like bovine, wildlife, and even humans, they're dispersed among the clades. So it doesn't matter the genetic makeup, they will be transmitted between animals and people and between cattle and other host species. There's long been thought also, and it is a case that the human-to-human transmissions of Mycobacterium bovis is rare. There are two things we need to take into account. One is the fact that there's a great proportion of Mycobacterium bovis disease in humans that is extrapulmonary. So the fact that that is extrapulmonary, so it will be hard to have, of course, transmission between humans. But even in cases of pulmonary tuberculosis, it seems that Mycobacterium bovis is not as efficient in transmitting as it is a Mycobacterium tuberculosis. And we can see even by the fact that Mycobacterium bovis is not out competing tuberculosis worldwide. So Mycobacterium tuberculosis is much more adapted and seems to transmit really well, while Mycobacterium bovis is not that case. But I just want to bring this here, that is not impossible. You know, there are some well-documented cases of transmission of Mycobacterium bovis between people. And of course, it's not likely to persist and lead to a huge outbreak or take over Mycobacterium tuberculosis in that place. But it's something that, as a medical doctor, for instance, you would have to think that even if you have a family of people that would have Mycobacterium bovis, you could have one person passing to the other. And when we talk about the impact of zoonotic TB, in Dr. Fujiwara was very clear in that the estimates about having 140,000 new cases every year and around 12,000 deaths. There is a huge challenge, and it's the fact that we don't diagnose Mycobacterium bovis in people. So there's no differential diagnostics routinely done, right? So smear microscopy, you only get to the level of Mycobacterium tuberculosis complex. Gene expert, you only get to the level of Mycobacterium tuberculosis complex. In culture, which is sometimes done, it may not, people normally don't have the follow-up test and need to identify if that isolate is really Mycobacterium bovis. And sometimes they don't even have the setup properly done to have Mycobacterium bovis being cultured, because we need a little different culture conditions for Mycobacterium bovis. But it's important to think that the burden of death and disease is underestimated, but is likely high. And the fact that Mycobacterium bovis is often associated with extrapulmonary disease, often a delayed diagnosis, which makes an increased burden of this type of disease in the context of tuberculosis in general. And the fact that Mycobacterium bovis is resistant to pyrazinamide. And even if we don't think about the disease patient itself, we need to think about the indirect problem that bovine tuberculosis takes on the most vulnerable population. Because many people, the livelihoods of people that depend on livestock are affected when you want to implement some type of control of bovine tuberculosis. And this also leads to food insecurity. So bovine tuberculosis is a chronic disease in cattle. It's not a disease that will lead to enormous mortality. So it is hard to control because of that aspect. But so once you actually add a program, if you don't make this program suitable for the most vulnerable and the smaller farmers, it's hard to make it effective. Because the way the programs are done now is that if the animal is tested positive, it has to be cooled. If the animal is cooled, then you have to have some type of payment for that animal. You cannot just eliminate a whole herd, or even if it's just few animals of a family that depend on that for the living. So most low, middle income countries, they do not have a program of animal TB control. And of course, even as Dr. Fujiwara stressed, they don't have a zoonotic TB surveillance at all, right? So the places that are really at the higher level of risk for animal-human transmission, they don't have zoonotic TB surveillance. So all the data that we're getting about zoonotic TB are probably not really showing the real picture, right, of zoonotic TB in the world. There are 12 countries with TB surveillance in humans and specific zoonotic TB surveillance. And those countries are all upper middle income or high income. Those are Australia, Canada, France, Ireland, Italy, Mexico, Netherlands, New Zealand, Spain, Switzerland, United Kingdom, and the United States. With their results and all the surveillance that they have been doing, there are some things with that the scientific community was able to grasp. Is that one thing is that the surveillance is mostly passive. So there are no identification of key populations, there are no target active surveillance going on to really see the impact of zoonotic TB. There has been a rise in zoonotic TB detection in the United Kingdom and Mexico. And there is a predominance of zoonotic TB cases among migrants from neighboring countries into the USA. And this is because USA has a mostly eradicated bovine TB. There are some pockets of infection in Michigan because of deer that gets infected, but the disease in cattle is well controlled. So most likely the transmission is not occurring within the country. So that's why there's this detection of zoonotic TB among migrants. And there is also seen higher mortality rates among zoonotic TB cases when compared to TB cases by Mycobacterium tuberculosis in the Netherlands. And then we have to think about the fact that it's mostly extrapulmonary, so there are many factors going on that may explain that. So there are anecdotal studies, these studies are all made, this is a study that was made in one center of TB. There's no systematic evaluation, as Dr. Fujiwara was very clear about that. But there was some reveals that show us a little bit about what can we start to expect in some countries. So we see that the low-income countries tend to have a higher prevalence on the few studies that were done of zoonotic TB among the tuberculosis cases in humans. Lower middle-income countries, so as it decreases as high as you go in terms of income, right? There's some outliers. So you see that there's a study in India that was like 10% of the cases were zoonotic TB. And there's a study in Mexico, we're going to talk about it, they're 26%, which was the highest rate ever recorded. So let's go to the study in Mexico. So this study was done in 2015. And the group was surveilling a period of from the years 2000 to 2014. Is a referral lab in a hospital in Mexico City. There were 1,165 isolates. There is a great proportion there of people that were HIV positive. And 26.2% of those isolates were Mycobacterium bovis. So Mexico is speciating, right, the isolates. So that's how they're able to really get these numbers, this surveillance, right? But it is a very high rate. It's the highest rate ever recorded, right? 54% of these cases of Mycobacterium bovis cases are extrapulmonary. So it takes really hard for us to really see the impact. It makes it harder, right? The impact of zoonotic TB. But we cannot forget that it also is possible to have pulmonary TB by Mycobacterium bovis. I want to stress that because people just assume and use that as even as a diagnostic tool, and it's not 100% extrapulmonary, right? And there seems to have been a rise in cases from 7.8% of the cases in 2000 to 28.4% in 2014. But there is a little variation among, over years. So it is really hard to see if it's really increasing or kind of maintaining. I'm not really sure. And there is resistance also going on in Mycobacterium bovis, not only, of course, pyrazinamide, which is not tested here, but rifampicin, azoniazide, and other first-line drugs. And the authors discussed in this paper that they attribute this possibly high zoonotic transmission due to the fact that 30% of the milk production in Mexico is sold without pasteurization. And there was an overall prevalence of bovine TB of 16.5% among dairy farms. If we go to the United States, where the surveillance with speciation is also going on. So the period from 2006 to 2013, there was a prevalence of 1.45% of the cases being attributed to Mycobacterium bovis. And over the years, this has varied from 1.3 to 1.6. You can see that most of the cases occur in the West with the neighboring country, Mexico, and 64% of the cases are extrapulmonary or both, right? Extrapulmonary and pulmonary. And you see that most of the patients are of Hispanic ethnicity, and most are also foreign born. So you see in the graph in the upper left. And but then if you look at those, it's like half of those patients, they have been living in the US for more than 10 years. So it could be two things. One thing is that they got infected when they were living abroad, when they were born and living abroad, or and then there was a long latency that they reactivate later on, or there is really a transit of patients that of people that consume products from dairy or dairy products in general, raw milk, because of the close approximation with the border. So if you take a closer look into California, which would be, of course, where most of the cases in the United States then is when you see a higher proportion of cases being attributed to Mycobacterium bovis, from 3.4 to 5.4% of the cases. And the associated variables with it are also Hispanic ethnicity, extrapulmonary disease, diabetes, and immune suppression. In this case was not HIV, other causes of immune suppression. So this also put into perspective this, I think there was a question even about that for Dr. Fujiwara. And then when you come to a study that was done in Argentina, you see a different scenario. So you see a 0.4% prevalence, and okay, we can say that it's not about that. The thing is that what was different in Argentina is that 65% of these people that had zoonotic TB, they had occupational exposure. So 31% live in rural areas. And then 74% of the cases were pulmonary. They were not extrapulmonary. So then here you see that most likely the cause of zoonotic TB in Argentina, at least in this center, was not due to the consumption of unpasteurized milk, the intake, the consumption of food that was contaminated. It was probably due to exposure, right? So people that work in slaughterhouses, in butcher shops, in tannery, that deal with leathers and handling meat for pets. So this is a population that is at risk for infection. And then you see that I showed you just few studies, right? And that's really the reality. And then I remember when Dr. Muniz asked me to give this lecture, she said, well, you can talk about zoonotic TB in Brazil. And then I thought, well, but I don't know. I mean, we don't have no surveillance of zoonotic TB in Brazil. We don't know what's going on. We have a national program of bovine TB control, and that is partially effective, I would say, but we have no idea what's going on in terms of zoonotic TB. So, and it's even harder because it's in Brazil, we have a very strong pasteurization chain, right? So the most cases, of course, of TB in humans, they occur in target areas like in cities and not in the countryside. And then we focus most of the efforts that we have in these populations, and we don't actually have the resources to cover the countryside, which is probably where most of the people that are at risk for infection with zoonotic TB are present, right? But regardless of not having a surveillance of zoonotic TB, we need to have, we need to start somewhere, and then we need to know the situation of bovine TB in general, right? So the Americas have 25% of the cattle herd, South America, sorry. So you see that apart from India, Brazil, United States, Mexico, the herds are really, really big, right? So there are some, and I'm focusing now more on South America, which is what I was able to grasp. but we see that the countries, most countries have a bovine tuberculosis control program. Surveillance is not, sometimes they don't get the whole country, but at least we see that there is also a lot of heterogeneity within the countries. But there is a prevalence of herd that can go up to 10% depending on the country. And then prevalence of animals, of course, it will be lower, but it can go up to 8.6%, for instance, in Ecuador. So there are a lot of cases going on, even when you have semi-structured programs of bovine TB, right? I can talk, of course, more about Brazil. In Brazil, we know the latest survey that was done was 2016. There is another survey that is coming out now, but we had a herd prevalence of 0.36 to 9%. We see there's a lot of heterogeneity within the country. In animals, the prevalence was between 0.035 to 1.3% of the animals. And the prevalence is very low in beef cattle. It is higher in dairy basins, and that's why you see a lot of regional differences, because the dairy basins and the cattle and the beef herds, they are also differently spread out in the country, right? We are now in the beginning when the program was made. It was national. It is still a national program, right? But the strategies were at the national level. And now the national government, the federal government is giving much more responsibility to state governments, because it will probably follow, like many other diseases in Brazil, that we have areas that are free of TB. We cannot guarantee that it will be much too hard with the resources that we have right now to be able to get a free TB country, but we can get free states. So there are some states, for instance, Santa Catarina here, they're coming to our eradication phase. And that's, and the importance for this, which is, it's very cruel to the Brazilian population, is exports. It's not because of the inside market, right? It's not the Brazilian market, it's to export. So this is something that it's how Brazil is coming out with this. And when we think about TB, we also start to think about measuring the risk of zoonotic TB transmission, right? Because there are many gaps on that, on things that we really don't know what is the risk. So you have the close contact with animals. So people that work with animals directly, this is it's a key population that we need to focus on. And there is the public that consume the products that come from animals. And even when we think about the products in general, we have to, it's not every product, right? So commercialization of unpasteurized milk, for instance, is illegal in Brazil. You cannot sell unpasteurized milk. That's illegal. It's against the law. But consumption of unpasteurized milk, it's something that we cannot control. It's very cultural, right? So it's something that is really, it's harder to manage. And there's no means to control that. There's no means to do some sort of escalation on that. So when we think about pasteurization and food safety in general, like, okay, we need to think about, or not food safety in general, but the ways we can treat the products that come from animals to avoid disease transmission. We are only thinking about one small piece of the whole chain, you know. We cannot fight zoonotic TB with pasteurization only, right? We need to have the control of the TB in the cattle. We need to have control of TB, I don't know, in countries that have problems with wildlife. You know, we have to fight the disease at the source. We cannot keep trying to make the product better without thinking about the animal, right? So we need to think about the whole chains. We need to make, okay, artisanal cheese is something that a lot of people will consume. It's something that it is sometimes even growing. And we need to guarantee that the chain of artisanal cheese is able to use a product that has an origin that is trustful, right? So there is some, and with that, there's also research gaps. For instance, we have no definitive data on the ability of bivalves to survive different process of artisanal cheese production. For instance, we believe that the viable cells likely decline during ripening. For instance, if you have a cheese that was produced with raw milk, and then fresh cheeses are probably much more problematic in general, but we really don't have any data on that. We don't know, right? So these are some of the things that in the food industry that we need to address. And then thinking about all that, how can we control zoonotic TB? And I don't want to repeat what Dr. Fujiwara said about what One Health is, but we really cannot control zoonotic TB applying the same exact strategies we use to control TB caused by Mycobacterium tuberculosis. And this is very clear, right? The epidemiology of the disease is different, and we need to focus on the links that will break the chain, right? We need to remind ourselves that it's a foodborne disease. We need to remind ourselves who is at risk. And who is at risk is different in every country. Because some countries have, there will be more structure in terms of pasteurization, for instance. They will have different cultures in terms of the food they eat. So it also, one recipe for the world will not fit, right? We need to, each country needs to think who are at risk. Who are the people that are really facing the risk of getting infected? And this will change in each country. And we need to think in a One Health approach, which is basically a collaborative, multi-sectorial, transdisciplinary approach that really recognizes this interconnection between the people, animal, and the shared environment, plants in general, right? And in shared environment, this is important too in bovine tuberculosis because it is, we have infected wildlife. We have infected wildlife that is transmitting back and forth with cattle in some countries, right? So we need to really focus also on that. We need to see how can we address this wildlife cattle interface. And then I brought here the roadmap to control TB, which was really well explained by Dr. Fujiwara, and but with some of my thoughts about it, right? So things that I believe we really need to focus to move forward, to really try to implement some sort of controls in zoonotic TB. So improve the scientific evidence, and this is in every chain of the cycle of zoonotic TB, in every link. There is so many things that we need to know, right? There's overall lack of information about zoonotic TB in general, right? So if we don't know the size of the problem, how can we try to avoid it? How can we fight for funds for it? You know, if we don't know how many people have zoonotic TB, there's no way we're gonna really put this as a priority, or, you know, it's part of the plan for most of the countries. We need to get to the countries and prove them, okay, you have a problem here and you need to solve this, right? And for this, we need to improve diagnostics. There's no species identification in 99% of the countries, right? There's nothing related to that. So we need to collect and report data, and we need to integrate systems, because we have a system that notifies bovine tuberculosis that is completely unaware of the system that notifies tuberculosis in humans, right? We need to overlap this information. Where are the outbreaks occurring of bovine tuberculosis? Who are the people that are in contact and consuming those products? And those are things that need to talk to each other, right? That's the multi-sectorial part of it. In case of Brazil, we account for the highest number of TB cases in Latin America, because we're a big country, of course, and we are a high burden TB country. And as how the pipeline is set up now to diagnose tuberculosis, the only way for us to really know if it's Mycobacterium bovis is if we have the isolate. There's no other way, right? And we culture half of TB cases in Brazil, not even that, right? And the culturing of Mycobacterium tuberculosis is highly connected to priority populations. So it's incarcerated people, people living in homelessness, HIV positive. And these some of these priority populations, and not all of them, like to generalize, but they're not really the ones that are likely at risk for zoonotic TB infection in Brazil. So if we don't do active surveillance first, identify the populations that are at risk, and do active surveillance on those populations, in the Brazilian scenario, which is a country that has a good pasteurization plant, has a fairly effective bovine TB control program, we will look for a needle in the haystack, right? So we need to really identify key populations and do active surveillance in those key populations. We need to reduce transmission at the animal-human interface. The only way to do that, there is no better way to control zoonotic TB than controlling the disease at its source. We need to control bovine tuberculosis, right? As I said, it doesn't matter if we have a perfect pasteurization plant. People will still consume raw milk or cheese made of raw milk. So we need to fight the TB at its source, right? With that, we need to improve food safety practices. To improve food safety practices, we need to, get into those artisanal cheese production factories and all that, and really connect them with the best source, product source that they may find, right? Improve animal health in general, right? Exercise control eradication programs. It is not easy because TB is a chronic disease, and it is not easy to convince and to really put the investment in controlling tuberculosis with farmers. So there needs to be money put into it. Otherwise, it's really hard to control and eradicate the disease. There needs to be political will. The same way Dr. Fujiwara was talking about political will. In the human medicine, we need political will in the veterinary medicine. Otherwise, it will not happen as well, right? And identify key populations, as I said, do an active surveillance instead of a passive surveillance. And the third part was the strength intersectoral and collaborative approaches. So we need to, people from different sectors need to talk more. So I am here a veterinarian, I'm talking to you, which I mostly believe are from the human medical side, right? And that's what we need. We need to exchange ideas. We need to say, I need to tell you, oh, this is the problem we face with controlling bovine TB. And then you have to tell me, oh, this is the problem we face with the surveillance of zoonotic TB. And we need to talk to each other. Otherwise, we will not be able to control this. Their joint interventions need to be done. For instance, it's very common, and I teach also medical students, and it's very common for them, they have no idea that tuberculosis can be also caused by Bacterium bovis, that we can get tuberculosis from animals. And so it needs to start even from, how we are educating our medical and nursing and health professionals in general, right? And address the various research gaps. And I think that one thing is develop rapid molecular tests that can differentiate TB and bovis. We need to put this in Gene Expert. Why haven't we had yet? We need to make it a difference over there. The rapid molecular test. Of course, Dr. Fujiwara said, oh, we need to move away from smear, and that's how we should do it as well. Differentiating between bovis and tuberculosis. Otherwise, we don't know the size of the problem. We'll never know the size of the problem. We need to improve data on treatment outcomes of patients with zoonotic TB. To identify the size of the problem, we need to also identify the hurdles of it, right? The challenges. So, I'm almost done. I think it's the one. So we need really to find this. We need to improve diagnostics of extrapulmonary TB because a lot of cases of zoonotic TB are connected to pulmonary disease, right? We need the strategy to control animal TB in cattle, wildlife, and their interface. We need a strategy to improve compliance to bovine TB control programs. And this is something that it's a major hurdle in the control of bovine tuberculosis. Better knowledge about routes of transmission and what is the risk of a cattle that is infected of excreting the bovis in the milk, and that milk getting to a person, right, to be consumed. And of course, the development of TBC vaccines for both bovine TB and human TB. So I would just like to say thank you for the invitation and everyone that worked in the lab, and it has been very important for this work with Mycobacterium bovis that we have been done the past year.
Thank you very much, Dr. Ana Marcia. Muchas gracias a la doctora Ana Marcia por una conferencia muy interesante.
Thank you, Dr. Ana Marcia, for such an interesting presentation. This subject is fascinating. And now we can open the Q&A session. We have already a few questions here. Dr. Ana Marcia, I'm going to ask questions in Spanish. So Claudia, the interpreter, can interpret them into English for you if you want, or you can listen directly to Spanish. The first question is, TB control, so ZTB control depends more on diagnosis, identification, differentiation between M. bovis and MTB. So what can be done to control the zoonoses in the context of One Health, within the approach of One Health, for those countries that cannot do molecular diagnosis?
It's a tough question. Okay, so it's I think that yeah, of course, when we estimate the size of the problem with molecular tests, well, of course, we have a much better grip on how things are going on in the country. But the surveillance of bovine tuberculosis itself, it's something that will give a lot of idea of how bad things are, right? So, and bovine tuberculosis is also, the diagnostics is also done with tuberculin, for instance, right, in the neck. So it's not something that is expensive, but it's something that needs to be structured, right? So it needs to it has to have a program, veterinary service that is really able to implement and do the diagnostics, right? And is willing to take action once the animal is positive. So when we have both things have to walk together, right? We cannot keep doing zoonotic TB surveillance without having anything in the veterinary side with bovine TB, right? We need to have a program of bovine TB. With that, we're able to estimate the risk. And as I said, each country will be different, because some countries, I'm talking in my privileged way here in Brazil, where we have a good pasteurization plants and we have a good system of food in general, but there are some countries that don't have any pasteurization plant, that every milk that is consumed is basically is raw milk that people heat it up, right? So it is something that it will be different from country to country. So and I think that even though you don't do a surveillance able to speciate between bovis and tuberculosis in the lab for zoonotic TB, you have to start in the animal side. That's how you control it, right? You have to start in the animal side.
Okay, next question. En áreas donde la tuberculosis bovina tiene
in areas where bovine TB has high prevalence for dairy products, how important it is to be able to differentiate the type of mycobacteria that affects humans before implementing treatment, and why this is not done regularly in Latin America?
I'm sorry, the treatment of TB in animals.
El tratamiento.
Where bovine tuberculosis has a high prevalence in dairy farms, how important is to differentiate between the type of mycobacteria affecting humans before implementing a treatment, and why this is not done regularly in Latin America?
Okay, so it is important for us to differentiate between Mycobacterium bovis and tuberculosis in humans because of pyrazinamide resistance. So all Mycobacterium bovis will be resistant to pyrazinamide, right? So that's one point of importance on why we need to really, if we think at a patient-centered view, right? Just thinking about the patient itself, herself, himself. So it's something that we need to, it is important to differentiate. Why isn't it done in countries of Latin America? I think it's all about what Dr. Fujiwara did, right? Said it's about political will. It's about really recognizing the importance of it. In Brazil, people think that it doesn't happen. That's why they don't differentiate in the lab, right? They say, oh, it's not a problem in Brazil. But I don't know, we never tested, right? I do think it's, if you take a general, that's my catch, like thinking about how the program of bovine TB control is. But for instance, I think that in general, our average will be very low because of the food chain that we have and how most of the people consume products. But I think we have key populations that are at risk. And those people, we are not really looking at them, right? So, and that's the thing. We need to start searching for it to really find, to really tell people, hey, this is important. We need to go and check that. And we talk about treatment of the person that has zoonotic TB. But the problem with zoonotic TB, it's more at the population level, right? It's because we will never control zoonotic TB with the tools we are using to control Mycobacterium tuberculosis disease. It's a different epidemiological cycle. We need to control differently. And so we will never end and reach the goals that we need, right? To end TB in humans.
Okay, next question, kind of a similar. En América Latina, es claro que
in Latin America, it's clear that in order to reduce this disease in humans, it's important to address TB in animals. Why is it that there is not enough coordination between animal health authorities and public health authorities? Why is that?
I think that's widespread. It's not only because of TB, right? It's we never really talked, right? I think that I'm a professor and I teach both sides. I teach both veterinary side and the medical side, and I think it starts even in the beginning, right? The way we teach and for the medical, for the health professionals, the human health professionals, is very human centered. We don't teach this concept of One Health. They only know because of One Health now because of the COVID pandemic, right? So as long as we keep teaching and educating everyone that will be the workforce later on in only about humans, that it's only humans that matter, it doesn't matter the planet or everything that is around it or the animals, it will be really hard to make this connection later on. Right, so every disease is like, this is historical, right? And the sectors, they don't talk, and it's hard. Now in Brazil, we had the first meeting actually occurred some months ago about should we start to look into Mycobacterium bovis, and so far as it seemed that, okay, we have a plan, but if that plan will really be put into practice, that's, I think the pandemic brought this recognition about the importance of One Health, of the zoonotic transmission of diseases and everything. And I'm hopeful that in the next years, we will start to talk more. That's the goal.
Okay, siguiente pregunta. Se debe establecer.
Okay, next question. It's important to establish coordination with animal health department in order to make sure that all dairy products are pasteurized.
This is already happening, right? So there is a huge fiscalization on, at least there should be in countries. In Brazil, we have on how products are made, on how dairy products are processed and everything. There is this artisanal chain of cheese production that happens in many countries, and it's harder to make fiscalization of it, but it is something that then it goes to the city level, right? So for instance, this is something that, as Dr. Fujiwara was presenting, that a group of mayors, this is something that it's at their level of regis, right? They are the ones that need to step up on this. In Brazil, we have 3 levels of food fiscalization of animal products. So it is the federal, the state, and the city level. And when you come to those artisanal cheese productions, you come to the city level legislation, I would say. And so this is something that is already happening, and at least in countries that have a structured food safety program.
Okay. Siguiente pregunta.
Okay, next question. Microbacterium bovis is resistant to pyrrolacimactamide. However, there are some reports that might be resistant to other drugs. How big of a problem this could be at a world level?
I think that the problem with the resistance to pyrazinamide is that the phenotypic tests are mostly not done, right? So it's a huge problem now. We have the genome sequencing now helping out in some of the high-income countries to really find out. It is tuberculosis is intrinsic resistant to pyrazinamide because of mutation in the PNCA gene, and we think that this came from the environmental. Is not really because it was exposed to pyrazinamide in its evolutionary history. It's because of nicotinamide probably, so it's something related to the environment and where Microbiology bovis is. So there is some, I would say that there is a lineage of bovis that is very different from the others that is not resistant to pyrazinamide. But at least we assume that 99% of the common Mycobacterium bovis will be. And then Mycobacterium bovis will be subjected to gaining resistance, like to this selective of resistance, like tuberculosis in general. So the same systems apply, right? The problem is that is already resistant to one of them. And so it becomes a major problem in terms of becoming a multi-drug resistance or even XDR, right? XDR, extensively drug resistant.
Okay, we still have 3 more minutes. This question comes in English. Does Mycobacterium bovis have a latent infection? And if so, can result in person-to-person transmission?
Okay, latent infection.
Sí, infección latente, ¿quieres decir? Ah, bueno, pues la latencia si es latente o no, eso está en debate. Está en debate para esto, porque es algo que no se ha realmente establecido al 100%, porque la mayor parte de los animales que sería un problema si fueran latentes, sería un problema muy grande para el programa de control de tuberculosis bovina. La mayoría de esos somos positivos, tienen una lesión. Cuando los vemos en el matadero que tienen una lesión, ha sido un debate, asunto de debate. Creo que hasta ahora tenemos que estudiarlo para ver si los sistemas genéticos de Microbacterium bovis puede entrar dormirse por un tiempo y volverse latentes.
Tuberculosis, and see if these systems are functional and as well in Microbacterium bovis. So I don't know what I answer because we don't know in general, right? So it's something that, and actually latency can be even different from host. We don't know that, right? How is the effect of host species on the ability of a pathogen to enter into dormancy and then latency? We don't know that. We don't know the answer for that.
Okay, one last question. What strategies can be implemented for establishing a strong working integrated system between different sectors in the context of One Health in controlling zoonotic tuberculosis?
It's a tough question, right? Because we need to address many points here. I think that in some countries that have a bovine TB control and also a human TB surveillance or human TB control, they're much more prepared to initiate this conversation. And they have normally they have two systems that are working together. And I think that one strategy would be to, once an outbreak of bovine TB is detected, that the regions, where this outbreak occur, they need to become focused on the human TB side, on really targeting the transmission and looking for cases of zoonotic TB. And also strengthen the awareness of food consumption for those key populations. Another point is also the work secure. I don't know how to say that in English, but the legislation that regulates the work force in terms of safety, right? So people that work in slaughterhouses, that work in butcher shops and everything, they should be really screened for TB. They need to, their health needs to be taken into consideration, and to, occupational exposure to really deal with. And those are two levels in the human side that can work together. So you have the departments that take care of occupational exposure, which I don't know how to translate that, but then you have the departments that oversee the whole detection of TB. And then you have the veterinary side, which can tell you, okay, this is a region that we need to focus on. And I think that's one way of putting together both programs to work for good.
Very well, thank you very much, Dr. Ana Marcia. Finally, can you give us some personal comments, professional comments about the questions made in this time to you?
No, I like
the question. About the question.
Say that again.
What do you think about the questions made to you today?
Those are very challenging questions, I think, right? Like, and things that we don't even have the answers completely, right? And I think most of it is they're not questions that can be answered by only one person. It has to be collectively, I think. So the questions are challenged this way, like, which strategies can we put together to make, how can we put sectors to talk to each other more? This is such a massive challenge, I think. And so those are very good questions.
Ok. Muy bien, muchas gracias a la doctora Ana Marcia, una excelente presentación. Gracias por responder a las preguntas.
For answering all those questions. And also want to thank our sponsors, Bacmoy and Beside. Want to thank our interpreter, Claudio Valencia, who did the interpretation for both conferences. Also, the English conference will be available on RemiTB YouTube channel. I also want to thank the entire team for YouTube, Facebook, and Imagen UABC TV, our friends from the PEPA, the UABC in Mexicali. Thank you all for being here, and we want to invite you next week for a special session where we're gonna award those participants of the Dia de Muertos literary contest organized by the University of Baja California. The terms and conditions for participating can be found on the www.remitb.org, or you can also go to the Facebook page for RemiTB. You can also email us to red.tb.mexico@mexico.com. So the deadline is October 31st, 11:30 Pacific time. We also want to inform you that the 5th session for the conference will be next Tuesday, November 8th at 9 o'clock Pacific time, 11 a.m. Central time. We can have a participation from Dr. Guadagil from the Tropical Medicine Institute and Alexander Humboldt by the Peruvian University, who will be talking about integrating molecular diagnosis for TB and COVID-19. We'll also have a presentation by Dr. Patricio Escalante, research doctor by the Mayo Clinic in the US, with new biomarkers for latent tuberculosis infection. Also, evaluations from the session 1, 2, and 3 are available, and they will be up for 1 more week. Regarding the self-evaluation for session number 4 will be available later today. The evaluations can be found at www.RemiTB.org. We encourage you to follow us on our social media, YouTube Divulgare, SS UABC, and Facebook RemiTB. That's all on my end. Thank you. Have a wonderful day.